And I know we have some research staff from one of our projects, associated projects. Did I miss anybody's role? No. Okay, so I think that just helps us in talking about our comments.
I'm Jess Mitchell. Like Alyssa, I fortunately or unfortunately am the current interim director of pediatrics at New Bedford Community Health. I am a family nurse practitioner who recently just became certified as a psychiatric NP as well. And that was primarily motivated because of the work that we have been doing with Team Up. I can sort of mirror a lot of what Alyssa's saying about when you train to go into primary care. Psychiatric care is not, it's kind of glossed over. You might encounter this at some point in time, but there'll be other people to deal with it. And I think it really took a turning point during the pandemic where that wasn't the case. We have 15, 20-minute appointments, and we'd be in the room with a patient who is suicidal, actively suicidal, with a plan for an hour at a time, with very limited resources. Connecting with the crisis center wasn't much of an option. Some of these kids ended up in the back of police cars going to the emergency room, which is really not a great place for an adolescent who's suicidal. And so as we integrated behavioral health clinicians into our team, not only did it keep us on time, but it also gave somebody who was better trained to go in and evaluate that child for safety. And do they really need to leave the office and go to crisis, or are they safe to go home and initiate counseling the next day or something along those lines? So it really just provided an open opportunity for that, just more applicable care. Further, as we moved through, and a lot of these kids are coming back into the health center more frequently for counseling, I found as the primary care providers, our behavioral health clinicians were coming to us. They wanted, we strongly recommend that this child, have medication to help support their mental health needs. And so now we're, kind of going down a different path. So very fortunately, I have connected with Dr. Kuntz and was able to ask questions, about this is kind of the scenario that's going on. This is how long they've been in therapy. This is what we're dealing with. Which medications do you feel are the best? But that's not always something you can do. Like she's not in my facility, so it's not something that's readily available, despite how available you have been. And so sometimes it's an email going back and forth, and you're waiting 2 to 3 days, and you don't really know what's happening with these kids. And so to me, I just felt compelled, once I got a little bit good at doing this, I was like, I really could be better at doing this. And so that sort of drove me to then go and get a secondary certification so that services that are not really available to these children will be more available to these children.
And how is that influencing sort of how your primary care team works together? So I'm just going to throw it out. It could be a help, but it also could be like, well, I'm going to turn everything to you. So it's a mix.
It's a mix. It depends on the comfort level of the provider. There are some who will hang on, they prefer to hang on to their patients. They know all of the siblings. And so they want to be the one who's prescribing and having those conversations. So they use me sort of in the same way that I've facilitated conversations with Dr. Kuntz to kind of, what's the first step? What's the second step kind of thing. Others are not comfortable at all and will just say, I'd like you to take on that part of it. And it's at least nice to be able to do that for them in those situations. And so it's really it's a blended mix of a lot of things.
Stephanie, can you talk a little bit about the work that you've done, sitting at health centers and being available for consultation, as well as the consultation that you provided to Team Up Health Centers?
Yeah, absolutely. And I should also add that
Can you skip that?
Oh, am I good? Okay. So I also work at Codman Square Health Center, which I think was one of the previous cohorts for Team Up. So in terms of my experience thus far, because I came into Team Up in around, I guess, this time last year, and from what I've experienced, it's definitely been, interesting trying to navigate cases when I'm kind of hearing them kind of maybe secondhand, third hand, and then saying, okay, does this meet a criteria for a medication intervention? Is it like, should we do the thing, or should we move on to, or should other things be considered? But I definitely have appreciated that that communication from the behavioral health clinicians that I have spoken to thus far, as well as the primary care providers who ask questions regarding the medications, and then also looking into if there is some hesitancy in terms of the medications, where that hesitancy comes from, because as a team, I would feel that if you have somebody with that specialty, you'd want to kind of feel comfortable asking those questions and feel comfortable kind of, reaching out and, work as colleagues.
And what kinds of questions do you get asked? Give us a range of the kinds of things that people come to you with.
So, well, we have, very basic of, okay, which SSRI or antidepressant, anti-anxiety medication would you want to consider trialing first? Is it one thing versus another? And then, well, why? So kind of looking at the most common diagnoses of depression and anxiety in children. And then a lot of times lately, it's been, there might be some sort of neurodevelopmental delay or history of autism. This family is coming in from out of the country because they couldn't get access to one thing. So they're looking for getting back onto medications here. What are the equivalents? Because, learned off the fly that medications that are outside of the country might not necessarily equate to what we have here in the States. So that's very nuanced and very complicated. So those have been the kinds of questions that I've been asked so far.
Dana will be next. And one thing that, just because our audience has quite a few behavioral clinicians, one of the things, Dana, maybe you could talk about, in addition to what you're planning to talk about, is thinking about how we as a team work together with psychiatry, because it's not just primary care to the primary care clinician to the psychiatrist. It's also getting the input of the behavioral health clinician and the family partner. So maybe that's also something you could cover.
Sure. We have a few hours, hopefully, here to discuss this topic. No, so my name is Dana Rubin. I'm an indecisive person, and that I've done several levels of training and not sure what I ever wanted to do in life. But I've landed here in a very lucky place where I'm a pediatrician and a child psychiatrist. And if you notice an MSW after my name, that is true. I do not have my LI, but I was, again, very fortunate to be in a joint training program with my MD and MSW. So I have that background as well. But I have to just share a funny story, because you're most behavioral health clinicians. So when I was in my MD MSW program, my mantra was I would never want to be a therapist. I would be terrible at it and I would hate it. And I think when I grew up enough and figured out that I might like it, that's when I went on to psychiatry. But I mostly focused on policy, worked with the Children's Defense Fund, did some other sort of policy level things in my MSW career. So just to explain all that. I've also had the privilege of working at Dorchester House for many years, and they were willing to take a chance on me to continue in my joint role as a pediatrician and a child psychiatrist. And it's put me in this very unique position of wearing both hats. So if you hear me going them and then me and then they and us, I'm very confused sometimes because I'm not sure which side of the aisle I'm sitting on. So what I guess I wanted to say, I wanted to first acknowledge the reality testing. I do a little reality testing with Alyssa to say that it is terrifying to have a suicidal child in your office. It doesn't matter how many years of training you've had. It's you still have that same, oh my God, I really need to go in 5 minutes. This wasn't supposed to happen. I have another patient waiting for me. So just to reassure everybody that that is a normal response, and that the key is having some kind of a template or an algorithm or someone to call to say, let me think this through and let's figure out what to do about this patient. I want to invoke that what we've really tried to do at Dorchester House, and it's taken a long time. I mean, what you're hearing about now is an evolution. I mean, people who come out of traditional pediatric training aren't used to dealing with these issues, other than responding on a test or sort of knowing the basic screening. And it has taken a very long time for people to be comfortable, not only screening, knowing what to do when you get a positive screen for depression, anxiety, ADHD, but also being comfortable starting to look at all the treatment options available to them. And if I consult to individual pediatricians or to behavioral health clinicians, or internally, I often do my who's on first conversation first, which is I want to know, and I think Stephanie alluded to it, tell me the whole picture. I'm not going to just tell you to, do 20 milligrams of Prozac. I want to hear what diagnostic work's been done, how this kid's doing in school, what other services have been implemented. Is there an IEP in process? What current stresses are in the family? Because that's really going to influence, as Stephanie said, whether or not we're going to move to medication sooner rather than later. It is a challenge in the pediatric world that many people, I mean, it's sort of like in the old days when pediatricians also weren't doing gynecological care at all for adolescents. There was just this, nope, I don't do that. I don't do birth control, right? And we refer it on. And I think there's many examples of that. We have kids with seizures, we have kids with asthma that we, in other years and other situations, may not have taken care of before, but we had to learn. We just had to figure it out with support, of course. And I think that mental health issues are sort of similar. And I really appreciate and compliment our pediatric staff for sort of stepping up to the plate. But it's been, I think, in the educational world, teachers help me out. I think it's called spiral learning, that we've done this many times. We've had many talks on ADHD, we had many talks on depression, and each time we either dig a little deeper or remind ourselves of how to approach it, both from a diagnostic and therapeutic point of view, but also from a medication point of view. So it's not, and again, I also sort of equate it to public health issues. Like, we know that educating people that smoking is bad didn't really do the trick, right? And so we have to, it's pretty similar in these settings too, is that we have to not only educate, but be available for ongoing consultation. And so I think that that opportunity that Team Up has provided to not just have consultation with a psychiatrist, but also family partners, mental health professionals, to help to continue to sort of learn about, as Alyssa said, take on the vocabulary, learn one, do one, learn one, see one, learn, see one, do one, learn one. I do backwards. Anyway, you once you've figured it out, you've done it with somebody, then you try it on your own. And if you need some help, you call somebody else. And I think that's a model that's really helped. I think in our health center, we started to call it bi-directional consultation, because in some ways, a warm handoff is not really the right words for it, because I think in our primary care setting, we're not really handing off the case. We're actually asking someone to come into the case and help us continue to manage. So that's sort of the framework we've used, and I hope I answered some of the questions you asked. Yeah. Did I get most of them?
Yes.
Yeah. Okay.
Any comments?
I just think, sort of to the same point, the collaboration with the behavioral health clinicians has really been kind of the key. You know, it seems we do the follow-up on the kids, you know, once every couple of months, sometimes even once a month, but if they're in therapy once a week for a much longer period of time, it's really important to have that feedback from the therapist. You know, is the medication working? Are they having side effects? Do they need an increase in their dose? Is there some other life stress going on that needs to be dealt with? Do they need follow-up sooner? You know, maybe they looked good a month ago, so you put them in for 6 months, but now they're in crisis again, so you actually do need to bring them back sooner. And our behavioral health clinicians, we have one in the front row, but they're really good about walking into our office and just saying like, hey, I saw so-and-so today, and this is what's going on, just so you're aware. Or, hey, so-and-so's in the hospital. They're going to be discharged next week. You know, they had been doing well, but then dad moved out, or whatever the case may be. And they're really good about keeping us in the loop. And it's not just, oh, we're going to give medication that's going to fix the problem. Like, we really do need to have that bigger picture of what's going on with these kids. Where are they at in their lives? Are they going to school? And they're really the people that are giving us the majority of that information, because in a 15 or 20-minute follow-up, you don't have time to dive into all of that. And so it's really understanding the different roles of the members of the team and actually collaborating with them to provide the best care for the patient.
Other comments before? Yes, that might be. So I'm wondering if we can have a discussion and get some suggestions about ways that we as teams might be able to work better to access what is often a scarce resource, which is psychiatric consultation. In terms of how do we prepare ourselves to gather the information that one might need to provide a consultant. What do we need back from them? And are there ways we can think about taking the experience that we collectively have had to really think about this as a model? We have some friends from Medicaid here, and I think that increasingly as we push sort of integrated models and we recognize the scarcity of child psychiatrists, being able to provide some guidance to practices that often have an integrated clinician about how to best interact with psychiatry might be really helpful. I think questions you might have had in your experiences in sort of as a behavioral clinician sitting between psychiatrists, between like the psychiatrist or the clinical team and the health clinical team and the sort of primary care team. But I thought that might be an area that as a group we could maybe provide some helpful thinking and share, put our heads together. Also, if people have just more general comments or questions or challenges that they have identified, that would be great to bring those out. Questions, comments? Sure.
Question for you: How do you feel that we can get other providers, definitely comfortable? She has the meeting. She's been wonderful. She's a wonderful director, so she's always willing to teach and guide the providers. But how can we engage other providers that are not comfortable, or that will just say, "Oh, we have that, so we'll just gather all the teams that have to say." How can we close that gap?
Yeah, we've talked about that. And I think I'm also going to turn to Alyssa and a few of the other primary care providers who are here at the audience to talk about what's made a difference for them. Who'd like to start?
I would just say that Dana taught me this, that if you should never walk out of the room feeling alone, right? And that's a very hard thing to take on, like that idea, that notion, because it is really often to you and the patient alone in the room. But she's like, if you're worried about a patient, don't worry alone, that you're doing it wrong. So you should always be asking for more help if you're this worried. And so one thing we just need is more time, honestly. So that becomes much more of a systems issue. And I think that if there was just more time, then I wouldn't be so scared to ask the prodded question that you know is going to get the answer that you don't really want to know, but you really should ask it because it's your one chance a year to ask the question. So having more time would be wonderful. And then we just do a lot more teaching now at DotHouse that I imagine, and I feel very grateful for it. And I think that that kind of a model of the constant learning, the constant bringing back best practices, the examples of workflow for different common mental health conditions is very, very helpful for us.
And probably like another, in terms of my experience over at Cognites, where it was always kind of meeting the providers where they were at. Also, it helped to like be physically there because then they kind of, to what you said, it's not feeling as though you're alone. But usually, and I tend to see that sometimes it's just there's, for whatever reason, there's that hesitancy of like, if I do this, will I affect the patient in a negative way? Am I going to make it worse? Is this medication, because this has a black box warning, or if I do this, is this going to push the child over the edge? If I ask the prodding question, is it going to get it into their minds that they're going to do the thing? Which, you know, if they already brought it up, it's already in their head. Not even asking that question lessens the chance of them at least going through with it, at least putting it out there. So there's that. And I think meeting the providers where they're at, kind of addressing the elephant in the room, addressing that discomfort, that could be a way of doing it. And then again, education, and communication. Is one example.
And yeah, I was gonna actually show this.
Sure.
Yeah. Yeah. So it is interesting, and I think that, you know, the people I've talked to, like, sincerely or are yeah, I mean, my conversations with other primary care doctors is not that people are, you know, like, don't want to do the work. I mean, I really talk to people, not quite in tears, but are very emotional and sort of feel very strongly about not giving kids psychiatric medicines, about, and in some ways, interestingly, understanding that most of the issues are attachment issues or trauma issues, and just really want the kid to get the treatment for the trauma, and really don't feel sort of philosophically like medication can fix trauma, which is true. But so many of our kids have such a high level of dysregulation that we can't even get to the therapy because they're so dysregulated. So, it's helped me to sort of have that perspective that I'm working sort of like with a family who has very strong feelings and cares deeply for their patients, and is wanting to do, so like Stephanie said, do no harm, but also really making sure that they're getting the right treatment. And I think sometimes it can be a both, and not just this or the other. So that's sort of what we've sort of been challenged with. And I think that at a health center wide level or practice level, sort of talking about it like, this is our practice, this is what we're going to do. It's not an individual. We're not, you know, I do keep using medical analogies, but it's not like I'm not going to take care of asthma because I didn't read the guidelines last week. You know, so they came into my office, I sort of have to take care of them. So I think having that kind of, but it has to be a supportive conversation, not a, you know, this is the rule conversation. But I wanted to show you, these aren't talks. So there's a couple of guidelines that have come up from the American Academy of Pediatrics, American Academy of Child and Psychiatry, that are a little bit dizzying, but workflows for how you do it in an algorithm of how you kind of can think about when to use medicine, how to use medicine. This is a process map for ADHD, for example. You know, to memorize them. this is how we translated that kind of a workflow into my favorite swim lanes. That's my new favorite brain graph. That talks about how we break it down, who does what, and really in a very visual way, sort of you can see how the team works. And you can't do any of this without the full team, right? You have the family partners, you have behavioral clinicians, you have the primary care doctors. And again, there are kids that need to come to child psychiatrists. Absolutely. You know, kids who are psychotic, kids who have probably have bipolar disorder. Like there are kids we need to see. So this is by no means saying that you should, that a health center should never refer to child psychiatry. But this is kind of bread and butter. And this is kind of what we do in our practice. So I'll just flip through these. This is an e-referral. So in our health center, we have some kids because of our staffing that are able to be seen in a warm handoff, and some people that just get referrals. So this is an example of that. This is something we're starting to work on, and I know a lot of health centers are starting to do more of these secondary screening for autism. But I just wanted to show you these will be available also afterwards. This is obviously from the American Academy of Pediatrics on a depression workflow. There's a part 1 and part 2 to this. They're also in the references at the end. This is the part 2 that goes a little bit more into medication. So I think using this as, our professional standards to go from, and then figuring out within your health center, could we just do part 1? And maybe that's a really good start. And having people become comfortable with 1 or 2 medicines like Focalin and Vyvanse or Adderall and insert those. Those are my ADHD medicines. If I get beyond that, I ask for consultation. Same with SSRIs. Most people get comfortable with, let's say, Zoloft and Prozac, or Zoloft and Lexapro, and then get used to using that. And then if they're beyond that, then ask for consultation. So I think you're expected to know all of child psychiatry, but here's some very focused things. Here's a path on decision making. Here's the people that are going to help you with making those decisions. Again, these are just our we help us create this. And we do you have any other comments on this work? But I just wanted to show you those just as sort of a framework for thinking about it and for helping to move the needle with it.
Dana, thank you. I think that was really helpful. And as someone who was sort of part of the discussions, one of the things that I think was really helpful was there was a whole group discussion about how to take that big guideline and make it work at the health center. I think that, and that was, I think that common discussion and then sort of agreement that this is what we can do, this is what we feel comfortable doing. I think helped sort of people get on board. Melissa, did you?
Oh, 100%. I just agree with this.
Yeah. Other Alyssa.
So I was just saying, it's also really, really hard when so many providers, especially therapists too, don't take Medicaid because of the low reimbursement rate. So not just here at DotHouse, the patients that I work with, but in the past 2, there's a lot of patients that have turnover on their providers, mental health realm, that I think it's at a certain point to the patients give up hope and don't know who to turn to as well. So it's just hard, like all the systems barriers in place to access.
I think you raised an incredibly important issue around health equity. I really see that being able to provide basic medications for behavioral and mental health conditions. If we don't do it in primary care, we know who can get access to that another way, and we know who doesn't. And so I think, given the populations we serve at the health center, there is no access to child psychiatry. There's not, how many child psychiatrists in the state private take well, actually any insurance. So I think if you're talking about providing full service, we have to deal with both bolstering our capacity as teams to provide that, as well as providing consultation models that allow consultation to child psychiatry for those kids that are too complicated. One of the things that, in response to your question, that I've always thought about is sort of having like this buddy system. Sometimes it's hard to say, I don't know, I don't feel comfortable doing something that your peers feel comfortable with. So I always felt like, like sometimes those buddies happen naturally, like you happen to work for session with a person, and that buddy system becomes sort of more formalized as a way to sort of say, okay, I have this kid, I think I do this, what do you do for these kids? And it's not quite so formal as going to psychiatrists. Maybe it's for the kids that you think you're supposed to be able to manage, to sort of develop that confidence, because it's almost like you have to get over that stage of like, I can't do this, and feel supported to take those first steps.
I think that's a great recommendation. Also, in the terms of the reason why I brought up the question is that we have a lot of designers starting with us, and so our population too. And so one of the things that's nice to me, and I hear sometimes a lot of like, oh, like, population serve so it's just making sure that those resources are in place and knowing that our health workers or behavioral health workers, they're going to support that and the warm handoffs, but it's also trusting that they're going to come to you if there isn't medication. They're not coming to the like right, it's not just closing off.
Comments, questions, or even challenges that you, as some of you as behavioral health clinicians or family partners, have in sort of working with primary care providers. We know it's not always easy. I think we have to acknowledge there are power dynamics in primary care, and often those are dealt with well, but often they are not dealt with. And so I think I would love to hear from you, like, where are the kind of places that for you as being part of the team and sort of negotiating that whole sort of different roles. What do you see? What would be helpful? What should we know? What should we take back to our primary care colleagues?
I'll say something.
Okay.
We do have a great team at New Bedford Community Center. I work very closely with Jessica. But there are other providers that have been challenging to me as a licensed clinician, as a provider as well. And I've been doing this for a long time as well. And so I think sometimes having that provider challenge my opinion on what needs to be done next is hard, is very hard to navigate sometimes. Those providers don't always like what we have to say, if we go in, we do the warm handoff where we assess as well. And we don't think that young teenager is at risk right now for whatever it is. And we get pushback sometimes. And that becomes frustrating. I personally have been able to navigate that, but there's other clinicians that haven't been able to navigate that. And I think we need to work a little better on educating, this is kind of what we do and this is what we're seeing. But again, I think it's that time. I think a lot of providers don't have that time to sit with us and talk because they're they've got to go on and see the next person, you know? So I think we have to create a better system of that, you know?
On to that question. So I really like that, and something that I was thinking of when trouble formulating how to say it out loud. So
Could you introduce yourself?
yeah, I just started at DotHouse. My name is Johanna. As a behavioral health clinician, and this is a little bit more from my previous experience in integrated behavioral health. Managing provider anxiety, I think, is something. So sometimes someone might come in, and maybe they're a young person, and maybe they're having some emotions, and some of the providers I've worked with have immediately jumped to medication after like a 6-minute interaction. And I based on my assessment, I'm like, I think they just need to call their family a little bit more first. Let's see how that goes. It sounds like they just moved here or something like that. And so in addition to like just not agreeing, I think there's like this anxiety of making sure I cover my bases. And as I sat there, I was thinking, well, what Dr. Alyssa mentioned was like the education piece and more learning. And I automatically had the same thought, which was there's not enough time in the schedule to block out an hour for didactics, like all the time, every time, and or just conversations, you know, just natural conversations. I also talk to providers while they're typing. And then they'll be like, they'll just nod, you know, really good skills, nodding every few seconds. But I'm like, are you really? So yeah, just balancing. So like, yeah, not agreeing, but also like that anxiety for wanting to make sure that they did something. And it's something that I don't see them be like next solution for.
Dana, then Alyssa.
Okay. Yeah, so one of the challenges, you know, that I've sort of tried to learn in my training is the role of a consultant, right? And in a particular way, where we are consultants to the primary care team, and that sometimes consultant, you know, as a consultant, people don't take your advice. So that's certainly one part of it. But I also, in the consultation relationship, you know, sort of thinking of that as a kind of a model. Is that, you know, sort of who is your client, right? Who is, you know, who do you need, who are you there to help? And in some way you're consulting to the primary care doctor. And I totally agree with Johanna that some of that is like managing their anxiety about the situation. And so sort of thinking about it as a consultation relationship, and that you're providing your expertise, and that it's really, in some ways, in the end, unless it's a patient that you're, you know, kind of, it's sort of who's taking care of whom, where, but up to the primary care vet, just if they want to do something different, but you have given your consultation. If your arrangement is different, that you're now in charge of the case, like obviously that's a different sort of dynamic. But I think that it's a little trickier in this model, sort of that sort of fluidity between being just a consultant, like I'm seeing this patient, here's my suggestions, you can go forward or not, versus, oh, you want me to now take care of the patient, but you're not following my advice. Those are like different dynamics, which I think, at least for me, it sometimes helps like define it, you know, as you're sort of in that process. And then the other caveat about consultation is that oftentimes we'll get called and you're like, this is stupid. Why did I get called for this? I don't know why, you know, they could have done this. And then you get there and it was actually really good that you went, but it was just the wrong question. So sometimes we get called and there's some other, they probably got some sense that something was wrong, sort of probably asked the wrong question, but it's really great that you were there because there really was a very good reason that they needed a consultation. So I think sometimes thinking of those kinds of models, although it's not exactly on point with Team Up, but that I think it helps like figuring out the kinds of conversations to have within the dynamics of your particular group.
I have a thought too about what Johanna said about managing like the anxiety in the room. I do feel like sometimes it goes both ways. Like I'll have a thought and then behavioral health has a thought. We've done a handful of times where we actually see the patient together. And that helps tremendously. it's a little bit difficult to coordinate. And it often takes like finding a follow-up spot on my schedule that they have an opening at the same time, or me just deciding it's okay to be late because this is important. And it often helps with my own anxiety, the behavioral health clinician's anxiety, but it also sort of proves to the family that this is truly integrated. We are all on the same page and we are all focused on the same goal.
And
It's
for the family, they're not repeating the story.
right. They're not repeating the story, or they're hearing the same advice. Like, because so many times, like the trauma related stuff and the ADHDs and it's parenting support, right? Like you're really looking for them to make changes that are then gonna, really show the changes for the kids. So hearing it from both of us at the same time, or the behavioral health clinician hearing what I've said to the parent so that they can either support it or re-explain it in a way that the parent understands, or kind of whatever the case may be. But I find that helps a lot with kind of navigating some of that anxiety. And you also get a better idea of what the behavioral health clinicians are doing within their visits, right? Because my general scope is not the same. Like we're looking at the patient in very different ways. And so, it's nice to see both sides of it.
I think there are a couple of questions. So then in the back here.
So, couple of things. One,
Could you introduce yourself, please?
yeah, I'm Michelle. Brought next with them about behavioral health. Couple of things. One, I agree with what everyone's saying. The relationship kind of the thing in some ways. And there's not a lot of time to actually communicate what's going on with the patient. But I think there might be a solution for it. One, what I've run into over time, not just in practice but other places, is that we may have an expertise in something, we may have an expertise in something else, and it's like because the provider is the provider, right? So seriously, that's like support staff. It's like, well, this is what I think, and that's what it is. So that's something I've seen over time. Other pieces, I used to work with PACE program. They have a program already set. They come together with, well, like everyone is different as a provider, a doctor, nutrition, everybody is in the same, and everybody is presenting whatever they can say about that patient, so they can all have a discussion about it. Everybody's on the same page, even though they have expertise. We all know what each other is thinking and how we're going to plan attached in that meeting. So not saying that we all have time to sit down and have meetings all the time, but I noticed that model was very helpful because everybody knew everybody was doing what followed up on, and those discussions were had even with family there if needed. So everybody would have the patient. Right now, it's like we should have tonight, and we just try to do the best we can. That's how we can. And then a lot of physicians are not like with our speech therapists. They're just there as the person like kind of talking, which I feel like it's up here. So with that, that's what I've been noticing. And which for me, it kind of makes the patient a little bit, because you can't get on the same page with providers. It's hard to do the job with the patient.
So thank you for that. And I just want to take that just one step further to think, what would it be like if you could actually get reimbursed? Like that was a patient visit, a comprehensive patient visit that maybe the patient's not there, but that all the team members are. I feel like for, at least for, well, now, especially, I don't know. I mean, we're sort of in this funny, weird big space because some people are fee for service, some people are not, so that the incentives sort of conflict for doing work like that where we work together as a team. But I think what you said in terms of, sitting down, how many people have the time to really discuss some of the really complicated cases? If we had that time in primary care, it would be huge. So, clinicians get, they think of half-hour blocks or hour blocks. We think 15-minute blocks. That's just not, you just can't do that. So I know we do have some policy folks. So I think thinking about, are there reimbursement codes that could work like that? Particularly that the reason I'm balking is primary care providers, we don't get reimbursed for visits anymore. So things that take longer, unless they make things more efficient later, they're really hard to do. So I think it's just trying to think about, hearing what we're hearing and thinking about how do we create an environment that supports that kind of teaming that we've all talked about being so important. I know, Alyssa, you had a comment, and that we'll get some final thoughts and wrap up.
Yeah, I was just gonna say, I think one of the overarching themes is how do you manage your own expectations and everyone else's expectations? Like a pediatrician have certain expectations that go in line with the behavioral health clinician expectations, and then the family may have a whole other set of expectations, and you can come up with this great plan or great recommendation and like say one to one, or I don't agree with that. So I think that's just important to keep in mind that like, yeah, people may not agree, but like you can have to be flexible in different situations depending on what's going on with the patient.
When you're thinking about that, so I like sort of what you said about, your expectations, the providers versus the family. I think you sort of always have to go back to the family. And that's generally where, like, if I have a disagreement with somebody, and this can be a medical specialist or otherwise, it's always kind of back to what's the outcome that we're looking for. Because it's not, I might think that this is a great plan, right? I had a mom come in yesterday and ask me for meds to keep the kid asleep. Well, it turns out her dad gets out of work in the middle of the night, the dog barks, the kid wakes up. I can't medicate that. So we need to work on a routine to get back to sleep, right? So it's back to what's the goal here? The goal is to get sleep, right? So, and that's what the mom wants, that's what the dad wants, that's what the school wants, so the kid's not falling asleep. Like, so it's, it's kind of renegotiating that. What's the outcome you're looking for? What the mom really wanted was for the kid to stop crying on the way to school. And so we sort of had to work backwards, right? Like I could have easily prescribed the medication to say, hey, this will help your kid sleep. Come back in 2 weeks, right? But that's not going to solve the actual problem on the table. And that's a simple example, but these things get a little bit more complex for sure.
The outcome take time. So I think a lot of people expect like a quick outcome or a resolution in like a week or two. It's like, like take a couple months.
That's an important conversation too when we start SSRIs, right? Like they take 4 to 6 weeks to work. And so families, by the time they may have been in counseling for 6 months, by the time they get to us and they're willing to accept medication into their kind of toolbox of benefits here, that's like another piece. We have to manage those expectations. I understand there's the black box warning, but it's not just about that. You might also be really frustrated that you're finally agreeing to take this pill and it's not going to help you for another month. Like just really putting it out there for them. And that's where I find it's important for us to collaborate with the behavioral health clinicians, because I can say like, hey, Liz, like this is how I explained it to the family. Do you mind just reinforcing that when you see them next week? Because they're not going to feel different next week. If anything, they might feel a little bit worse. And so, but she's going to be the one with the touch point over the next 3 weeks before I see the kid follow up. So it's, I know it's difficult. There's providers all have different personalities, and in an ideal world, we'd all be able to collaborate the way we want. I do think that the biggest thing is time. We often give up our lunchtime to have these conversations and things like that. I've been on the phone with Dr. Kuntz late into the evening hours, sometimes I think even on the weekend, just because it's the only time the two of us both have the time to connect. And for some of these cases where it's important, but there is no diagnostic code for that. I mean, you could throw a complexity code on some of this stuff, but it gets you $5. It's not worth your time. So there are a lot of systems problems that go along with this, but I think if we keep trying, we'll get there. Team Up has definitely been helpful, because before we had Team Up, we didn't have the resources to even navigate any of this. So, we're at least in a better place now than we were 4 or 5 years ago. But there's definitely still work to do.
Final comments from panelists.
Okay, so on a more optimistic note, I guess, is a couple of things that we've piloted thousands of things, so I'm telling you the things that I think worked a little bit. One is that our team is our behavioral health team is part of pediatrics. So whether we're talking about blood pressure or depression, the whole team comes to the meetings at once a week. And I think as small as that sounds, that I think has really allowed comfort. I think it helps to break down some of the potential hierarchy that exists. So if there's an opportunity to do that, it's a meeting that already happened. And we really, we think that's helped to some degree to sort of have more opportunity for other kinds of conversations that aren't necessarily in that heated moment with the patient around a particular issue. So that's one comment. The other, which it's small, but we made our referral to team up one referral. So no one's saying, I only want a family partner, I only want a behavioral health clinician. There aren't internal referrals for family partners. So, you know, we're just one group and our team is a team, so that it's not, because I think there was a tendency at first within our team to say, oh, the family partners, they just like get food for the patient, or they just get you know, a school thing, and they're this small thing at the end of the line. And it's not that. It's like the whole team is consulted at the same time. And I think those small things, I think it feels like they've made a difference in how people see their fellow workers, you know, that the family partners, just like the case Alyssa said, we have our family partners often take the first call. Not that they're going to do a mental status exam, but they can actually stabilize the family and then get the behavioral health clinician in. So in terms of starting to break down some of the silos and barriers, those are just two things I just wanted to throw out there that we've seen a difference with. Of course, ahead of time, we didn't know it was going to make that impact, but I think it has been.
Well, thank you, everybody. I hope this helped sort of foster understandings between all members of the team and give us some ideas about how we can really expand the role of what is done in pediatric primary care, particularly around prescribing, which we know is just a really challenging resource to get if it's not provided.